Sevgili
Evet. Dear participants and dear colleagues, I'm personally very happy to be face to face at this conference, and I'm very excited to present you Professor Wolfgang MIESBACH in this session. He is a professor of medicine at Frankfurt University Hospital and head of the Department of Hematology and Hemophilia Center of Medical Clinic and Institute of Transfusion Medicine. He is a member of national and international scientific societies, and he has a lot of publications, articles, and book chapters about hemophilia. His research focuses on rare coagulation disorders, new treatments, and gene therapy. Hi, Professor. We are very happy to listen to you. Please.
Yes, hi, dear Chairman. Thank you so much for this very kind introduction. It's a great pleasure and honor for me to give this presentation on gene therapy. It's a very great pity for me not to can join you in this wonderful Congress, and I also want to apologize for this delay. But thank you very much again for this invitation. It's a great pleasure and honor to me. And with this slide, you can see my disclosures. This is an overview about this 20-minute presentation. So I would like to start what types of gene therapy are being investigated and what type of gene therapy is most appropriate for gene therapy trials in hemophilia. How could we inform our patient about gene therapy, and what would be important for the patient to know what is associated with gene therapy? So what about the patient-informed consent? How does gene therapy work? So how would the efficacy and safety of gene therapy be investigated? There has been recently published new findings on the safety of gene therapy I would like to discuss with you. And finally, there has been suggested a hub and spoke model for the gene therapy delivery in Europe. Now, this is a slide about the gene therapy. So with gene therapy, we like to replace the gene who is lacking or who is not functioning. And this kind we speak today is the type gene transfer. You know, there are lots of other gene therapies and already approved and licensed, for example, CAR T-cell gene therapy. With gene editing, we look very much into the future and hope that there would be a much more detailed and precise gene therapy. And today we are speaking about gene transfer. And how does a gene transfer work? So first of all, we need a therapeutic gene. This is a factor 8 or the factor 9. And this therapeutic gene would be put in a vector. And for this reason, adeno-associated vectors are used because they are non-pathogenic, so not associated with the disease. And they have the packing size to that the gene of this vector can be replaced by the therapeutic gene. There are several isotypes known of this AV transfer, and they have a liver tropism. That means that the capsid and the vector are administered intravenously, and after this administration, the capsid transduces the liver cell, and from that point of view, after transduction of the liver cell, the capsid will go to the nucleus, and from the nucleus the functional protein would be produced and released. It's also important to note that, and this differs the adeno-associated viruses with other viruses, that in most cases adeno-associated viruses does not integrate into the genome, and this is very much important, especially regarding the long-term safety of this treatment. Now, through all the different gene therapy trials, several inclusions and exclusion criteria are important to note. First of all, only adult male patients with hemophilia A and with hemophilia B, mostly severe and in some parts also moderate hemophilia, have been included. First of all, the inhibitors against factor 8 and factor 9, also in history of inhibitors, was excluded. Also, the occurrence of a manifest underlying liver disease, and finally the presence of antibodies against AV, which can occur, and this differs from region to region, and they may increase with the age of the patient or were excluded. But the more we know and the more patients are included now in the phase 3 trials, it is probably that inclusion and exclusion criteria may change in the future studies. For example, there are some studies now planned for adolescents, patients with hemophilia, also for patients with inhibitors against factor 8 and factor 9, and also the presence of anti-AV antibodies may not play such a big role, because in some studies patients with these antibodies were included and they did very well. Now, how does the gene therapy treatment works? First of all, there's a lot to do before this treatment. So in the discussion with the patient, it's very important to discuss how gene therapy transfer works. What would be possible clinical benefit? Would it be possible to predict a certain outcome after the study? This is unfortunately not the case, so there is still a variability of results. And finally, who would be candidate for gene therapy and who would be eligible for gene therapy? So after all this has been done and the gene therapy product has been prepared, it could be infused, and this is in most cases a short infusion up to 1 hour of time. There may be some potential risk according with transfusion-related allergic reactions, but this can be managed very easily, and it can be that the patient has to travel to the dosing center in case if his home center is not his dosing center. Most important is a follow-up period. There's a very close monitoring required. In the first couple of days, the bleeding risk may remain as long as the factor production has not been initiated, and after then it may lead to a change in the daily life of the patient. It would be very important to note that alcohol consumption and contraception should be performed, and all should be done to maintenance the liver health. And because of a adverse event leading to ALT elevation and potential reduction or loss of factor expression, corticosteroids may be used. Now, before gene therapy, we already should start discuss with our patient, educate our patient about gene therapy. So how would be likely that the bleeding risk would change? So in some cases, for example, if the gene transfer does not lead to a normalization of the factor levels, there would still be a risk of bleeding, particularly traumatic bleeds. And also we should advise our patient that after successful gene therapy, there may be some psychological related issues, so-called loss of identity, and this may lead to potential anxiety and some emotional issues we already have experienced in some of our patients. After gene therapy, especially the first weeks, there may be an ALT elevation with the need of immunosuppressive agents. Maintenance of liver health would be important, and also to carry out any precautionary requirements to avoid the transmission of gene therapy particle. And finally, and this is what we do not know at all, because we do not oversee a very long time period, there would be the uncertainty regarding long-term safety after gene therapy. One of the motivation of the patient to undergo the gene therapy treatment would be to achieve a state of independent of hemophilia. And this can be achieved, but the first time it would be very important that the patient would come to very close and regularly follow up to the hemophilia center, which is needed much more often than in the time before gene therapy. And it is important that the patient understand the need for this and why this is important. Because regular laboratory measurements should be carried out to detect as early as possible some adverse reactions and some liver-related reactions, and also to initiate immunosuppressive treatment as early as possible. Sustained long-term factor expression may lead to change of lifestyle, and in some cases patient is not able to handle this for his own, and in this case also it would be very important to discuss these potential lifestyle changes with the patient. Now, with the next few slides, I would like to present you some recent trial results about gene therapy in Hemophilia A and Hemophilia B. First, to start with the most advanced gene therapy study from the company BioMarine, and this has been published in New England Journal of Medicine in 2020. The two highest dose cohorts showed a durable factor VIII expression for a time period of 2 and 3 years, leading to an ABR of 0 and nearly no need for factor VIII infusions. And this is a slide about this 3-year follow-up in this cohort, and we see that still 3 years after gene therapy there would be markedly increased factor VIII levels. One patient is clearly non-hemophilic. In 5 patients the factor VIII levels ranged between 11 till 36%, and one patient had a factor VIII level of 4% 3 years after gene therapy. Later in 2020, some more follow-up data have been presented, and leading to a 4-year follow-up in this cohort 3 and a 3-year follow-up in cohort 4. And we can see from this slide regarding the 4-year follow-up that even after 4 years there is a 95% reduction of the ABR, and quite similar in the lower dose cohort cohort 4, the 3-year follow-up still shows a 93% reduction of ABR. So we can conclude from this that in gene therapy trials of hemophilia A, patient achieved factor VIII levels within ranges which allowed to stop prophylactic treatment, and even after stop of prophylactic treatment, nearly no bleeds occurred and no factor VIII administration was necessary. Now, with this, I would like to switch to the gene therapy results of hemophilia B. Probably you recall that in 2011 and 2014, the first results of the St. Jude trial has been published in the New England Journal of Medicine, showing and demonstrating a proof of concept. That means it was the first study which significantly showed that gene therapy in hemophilia worked. And from this time on, several other studies have been initiated, and this is a study I would like to show you about the stable expression of factor IX for up to 4 years. In another study using an AAV5 capsid and a wild type factor IX, and you can see from these slides there is a stable increase and a continuous expression of factor IX in both those cohorts without great variability and without a loss or reduction of factor IX. In this first dose cohort, the mean factor IX activity was 5.1%, even after 5 years after treatment, and in the higher dose cohort, the mean factor IX activity was 7.5%. Much more interesting are trials using not the wild type factor VIII, but a factor IX variant with a higher activity, so the so-called Padua variant. And this has been published in 2019, showing in 3 participants using this higher activity factor IX variant, but at the same dosages as in the study before, that the factor IX activity increased even more from up to 33% till 57% up to week 26 after dosing. And in this trial, all participants had low levels of pre-existing neutralizing antibodies to AAV5, leading to the effect that probably in this study the pre-existing of low titer pre-existing neutralizing antibodies to AAV5 do not play that role we are used from factor VIII trials and do not lead to a lower expression of factor levels. This is also a very interesting study using a dosage of 5 × 10 to 11. And in this study, a follow-up up to 78 weeks has been presented. This study also uses the higher activity variant of factor IX, the Padua variant, and the mean factor IX was 33%. And it's not surprisingly that with this very good factor IX expression, there was nearly no more bleeding and no factor use in the great majority of patients. From this study, very recently, 4 years data have been presented, and they show that even after 4 years, there is a continuous expression of factor IX, leading to 0 ABR at year 4 after dosing. Now, this was a short overview about the efficacy. That means factor levels, bleeding rate, the need for factor consumption. And this, of course, has to be considered and related to potential safety aspect of gene therapy, because in hemophilia we already have very safe and efficacious treatment, and therefore it would be very important not to increase possible safety concerns in any treatment of hemophilia. And the main adverse event we saw already in each of the hemophilia gene therapy trials is an early transient hepatotoxicity. And this leads to a transaminitis and in most cases to an isolated increase of ALT. ALT is not really very high increased, but in this case it's up to 400, 500 units, but also in some other trials only a very mild increase of ALT levels can be observed. It mostly occurs in the first weeks and the first year after treatment. It is completely asymptomatic, so the patient do not have any problems and transient. But the problem with this is that it may indicate and also may lead to a reduced factor expression. What we see from the trials, it seems that it is dose dependent. That means the higher the dose, the higher the risk of this ALT elevation. It can be that it may occur more often after gene therapy in patients with hemophilia A and than with hemophilia B. And this is the good thing, it is treatable with immunosuppressive agents, and this is the reason again to have this very close follow-up after gene therapy, to start the immunosuppressive agents in most cases with prednisolone as early as possible. Now, this is a quite hypothetical. We do not know yet what is the exact underlying cause of this ALT elevation. Probably several causes may be important. First of all, it can be that there would be some inflammation and cell death in the transduced hepatocytes. It can be associated with a immunological response, because in some cases, but not in all cases, a T cell response can be detected. And finally, it also can be due to some kind of stress to the endoplasmatic reticulum because of the high number of transduced cells. There are some different treatment concepts from study to study. There are some different approaches. Immunosuppressive agents are used in most cases on demand, but they also can be used prophylactically. We know from the immunosuppressive agents that they may reduce inflammation and also have some influence on the T cell response. And in most cases so far, corticosteroids are used at different dosages, but also some other immunosuppressive agents may play a role. Now, finally, after the presentation of the efficacy data and potential safety aspects, we still have to admit that we still deal with some unknowns. And this is not very easy to have this discussion with the patient before, but this is what we know from this study so far. So up to now, it's not exactly possible to predict the factor level which could be achieved. Probably this will change. So more data we have from the phase 3 studies with a higher number of patients included, but there still is a relevant interpatient variability of gene expression. We do not know the exact reasons on the ALT elevation and what would be the best use of steroids. Vector shedding means that some DNA particles are released, and this can also differ from study to study. Durability of results, I would like to show you some slides now, and long-term safety is something which has to be very carefully followed up, and there's planned a long-term safety registry from the WFH to follow up every patient, any patient who has been treated with gene therapy. Now, this is a slide about the liver biopsy in patients treated with gene therapy of Hemophilia A. And these were two patients of the trial which has been presented during this presentation at two different dosages. And this has been done in the first patient at week 201 after treatment, and in the second patient at week 140 after treatment. In the second patient, also ALT elevation occurred, and this patient has been treated with prednisolone. And the second patient, however, and this was a patient in the higher dose cohort, had a continuous factor VIII expression of 28%, whereas the patient in the lower dose cohort showed no factor VIII expression. And it can be seen from this histopathological workout that vector DNA was primarily in form of circular full-length episomes. So there was no high-grade integration of the vector genomes. And as you can see from this slide, this corresponds quite well to the factor expression of the patient, whereas in the first patient there is nearly no vector DNA seen in this workout. Also very recently, long-term effects have been published in some dog models, and these dogs have been treated up to 10 years before with this one single intravenous injection of the gene therapy. So in the first publication, a stable and sustained factor VIII from 1.9% to 11.3% could be demonstrated up to 10 years. 2 of these 9 dogs experienced a gradual rise in factor VIII activity that was 4 times the steady state level. And there was some clonal expansion with integration in these 2 of these 9 dogs near genes associated with growth control and cancer. And this, of course, may lead to some concern. But throughout the years, no liver function dysfunction, no liver toxicity, no clonal expansion or evidence for tumorogenesis was detected. And this was very similar to the second study. In the second study, 8 dogs were followed for up to 10 years. And in this study, again, no clonal expansion or integration into intergenic regions has been detected. This is something which has been reported last year, so it led to very important aspect. In one patient treated in a phase 3 Hemophilia B study, a hepatocellular cancer occurred. And this was found by a routine ultrasound of the patient, so the patient was asymptomatic. He was prior exposed to hepatitis B and hepatitis C infection. And the AAV gene therapy took place only 1 year prior. this event, and in addition to that, there's also a history of non-alcoholic fatty liver disease in this patient. Now, regarding from the background I tried to explain, there was a lot of concern, and this also led to an immediate pause of the study. A lot of work has been carried out regarding the histopathological workout, and it could be demonstrated that there was no evidence of clonal expansion or any dominant integration event, and the whole genome sequencing confirmed that the HCC had genetic mutations that are independent of vector integration, so most probably not related to the AAV-based gene therapy, but related to the long-term exposure to hepatitis B and hepatitis C infection. However, we do not know the impact of prior hepatitis C infection in gene therapy, and this is one of the issues which is still needed to be investigated with the further follow-up studies. This study shows the longest follow-up after intravenous gene therapy. So this is a follow-up study of a study which has been initiated 20 to 15 years ago. This was the first study systematically infusing AAV vectors. This was an AAV2 vector. And unfortunately, there was only very small and transient increase of factor activity in this study, but it is now the longest clinical follow-up after the systemic AAV vector infusion, and these patients have been investigated with imaging, with several laboratory measurements, and even after 12 to 15 years, it could be stated that there is no major safety concern, no organ dysfunction or some other problems, and especially no cancer in these patients. However, the evidence from this study is quite limited because of the small number of patients included, only 4 patients. And it's also interesting that even 12 till 15 years after the initial dosing, there is still a persistent multi-serotype cross-reactive neutralizing antibodies, not only to AAV2, but also to AAV5 and AAV8. And this makes it impossible, according to the current knowledge, to redose and retreat patients with AAV-based gene therapy. Now, finally, how could gene therapy be delivered in Europe? And this is about the hub-and-spoke model. Recently, a hub-and-spoke model has been proposed by the EHAT and the EHC in Europe, and it has been recommended that gene therapy could be administered by centers who already have collected some experience and also have the technical possibilities to administer gene therapy. But in any case, patient also has to be followed very closely, and this is in most cases only possible at his home center. There may be a third kind of center, that means supervisory recommendation and coordination center, in case the dosing center is not able to do this. And so there may be 2 or 3 centers caring for the same patient in case of gene therapy. And this would be important in case, especially after approval of the drug, to make it possible that gene therapy could be delivered as efficacious and safe as it has been done during the clinical studies. So coordination and cooperation would be the key in this model to coordinate the laboratory measurements before and after gene therapy, and also to coordinate the traveling, because it has to be decided about the adaptation or the a stop of the factor replacement, about the early detection and treatment of ALT elevation and initiate potential immunosuppressive treatment, and of course the longer follow-up, which also would be very important. So with this slide I would like to end this presentation. Gene therapy research for hemophilia, the current clinical trial experience. We now have several studies in the phase 3 investigating gene therapy in hemophilia A and hemophilia B. We know from the early studies that gene therapy in hemophilia works and that it has a huge impact on factor expression, on the bleeding rate, so patient can stop prophylaxis and do not need additional factor concentrates in the great majority of patients. But we also know that there may be some possible adverse events of gene therapy. First of all, due to the immunogenicity, so due to humoral and cell-mediated immunity, the pre-existing anti-AV immunity plays a role, and the majority of the patient excludes patient with antibodies against AV, but there are also some studies where these patients are included so far. The main adverse events is a dose-dependent and transient AV-associated liver toxicity indicated by an increased ALT elevation, which can be treated by immunosuppressive agents. And so far, from the long-term observation, 12 till 15 years after gene therapy, as well as the liver biopsy studies and the dog studies, no gene therapy-related long-term safety event emerged so far, but further observation is necessary. And with this, I would like to thank you very much for your attention.
Dear Dr. Miesbach, first of all, I would like to thank you on behalf of the Organizing Committee of National Hemophilia Congress of Turkey for sharing your experience and also talking of clear presentation. Now session is open for discussion and questions. Acaba salondan gen tedavisiyle ilgili soru veya katkı var mı? Evet, Barış. Just one question, Dr. Miesbach.
Merhabalar, teşekkür ediyorum bu güzel sunum için. Benim sorum şu olacak. Hemofili B için bir nebze tamam kabul edilebilir ama hemofili A için bir vektöre konup tamamen yabancı bir dokuya, fizyolojik olmayan bir dokuya bunu sentezle diye göndermek ne kadar mantıklıdır? Güvenilir midir? Şu ana kadar bir sorun olmadığı aşikar ama vaka sayısı hem az hem de süre çok kısıtlı, izlem süresi. İlerleyen süreçte karaciğer dokusunun acaba orijinal fonksiyonlarını bozmayacağına dair bir garantimiz var mıdır? Bu birinci sorum. İkinci sorumda eliminasyon aşamasında, tedavi aşamasında kronik karaciğer hastalıklarının önceden varlığı bir eliminasyon sebebi midir? Bu da ikinci sorum. Erişkin hastalar için özellikle metabolik, enfeksiyöz veya işte depo hastalığı falan gibi olabilir bunlar. Bunlar eliminasyon sürecinde önemli midir? Teşekkür ediyorum şimdiden.
Yes, thank you very much. Great questions I would like to try to answer. So first of all, I agree. It seems as that there would be a difference in the outcome after gene therapy with hemophilia B and hemophilia A. So we saw more variability of responses and also a decrease of factor VIII expression in the hemophilia A trials. And it seems that in Hemophilia B trials, there is a more continuous and long-term expression. So this may have something to do with the differences between factor 8 and factor 9, the immunology, and also that the factor 8 is not originally produced in the hepatocytes. But if we oversee the longest running data now in the Hemophilia A trial, we also could confirm that there would be a persistent factor 8 expression up to 5 years without any major safety risk, and the patient were able during this time to stop their prophylaxis and lead a quite normal life. So this is really great, and this is a result which has not been expected before. So the time gene therapy trial started, so nobody knows how long could it stay and continue, and I think 5 years after gene therapy for Hemophilia A, this is a great result, and we are still not at the end. It would be very interesting to see what the other hemophilia trials are doing, but they started later on, and we have to wait for the results. Now to your second question. I think this is a key question you mentioned and you raised regarding the safety of gene therapy, because this is a liver-targeted treatment, and if you consider the high proportion of patients with a history of hepatitis C infection or hepatitis B infection, so the liver is not as healthy maybe as in other. And also you mentioned some storage diseases, and I can say that to my personal experience, we also have included patients with hepatitis C infection and a history of hepatitis B infection, but already treated. And they did very well. So to my knowledge, they did not saw a different outcome related to patients without this history, but it would be very important to very close this patient with imaging, so probably fibroscan if possible, and abdominal ultrasound and liver parameters to see how they are doing. And on the other side, it would be very important to discuss with the patients the importance of liver health. That means avoidance of alcohol and if possible some other medications.
Başka soru var mı? Dr. Miesbach, I have a question. Depend your experience. When the patient who has non-respond to corticosteroid therapy during transaminitis after gene therapy, what do you recommend for second option of immunosuppressive therapy?
Yes, also a great question. Thank you very much. And in fact, there have been a couple of patients who showed nearly no or only very small effects on ALT elevation after start of immunosuppressive treatment with prednisolone. In these cases, as far as I know the publications, it was switched to intravenous administration of prednisolone. So this has been done for 1, 2, or 3 days to give it intravenously. And also some other immunosuppressive agents are used in some other trials, for example, tacrolimus.
Thank you. Thank you so much for contribution for gene therapy to our colleague. Thank you.
Thank you so much.
Bye.
Bye-bye. Bye.